Okay, we've covered the diagnostic tests. This is video 5, and now we're going to look at collaborative care. Prevention of attacks. It's really important that patients stop drinking. Damage that is caused by the alcohol is irreversible, but about half the patients who stop drinking will have pain relief. That pain that's either chronic or episodic. When the patient is experiencing an acute attack, which can happen, so a person can have chronic pancreatitis, but if they still have live pancreatic tissue there, they can develop pancreatitis, which is treated just like acute pancreatitis. So when the amylase levels are elevated and the patient has a severe belly pain, they're treated, they have acute pancreatitis. Pain relief is important, and antiemetics can be used. Same treatment as acute pancreatitis. The diet is generally bland. They need plenty of calories because they're going to have an absorption issue. The carbohydrates and the proteins, those are going to be more readily digested and absorbed. Fat has to be low. For example, 50 grams a day. And the goal here is to control the diarrhea and the steatorrhea. As that decreases, fat can be increased to 100 to 150 grams a day. Pancreatic enzyme replacement becomes really important. Things like pancreatin, pancreolipase, these are tablets that actually contain amylase, lipase, and trypsin in them. These pancreatic enzymes have to be given with meals in order to, help digest the food. And then diabetes, if the patient has it as a consequence of their chronic pancreatitis, that has to be managed as well. Now, surgery is not a primary treatment, okay? But it may be done to relieve chronic intractable pain. It may be done to facilitate drainage from the pancreatic duct or to actually resect a diseased portion of the pancreas. Again, it's not a primary treatment. All right, that is chronic pancreatitis. Now we're going to spend a little bit of time, maybe the last 10 minutes or so. I don't know if this will all fit on this video or not. Pancreatic cancer. Pancreatic cancer. 42,000 plus people are diagnosed each year. It is the 4th leading cause of cancer death. It is more common in men and in African Americans. The only firmly established risk factor for pancreatic cancer is cigarette smokers. In people who smoke, they have 2 times the incidence of pancreatic cancer than in people who don't smoke. The cause overall is unknown. There are some associations with some things you see listed there: chronic pancreatitis, cirrhosis, diabetes, coffee, alcohol, high-fat diet. But again, the only firmly established risk factor is smoking. More than half the tumors are located in the head of the pancreas. In these situations, the common bile duct becomes obstructed and the patient presents with jaundice. Sometimes that's the only symptom they have. They may have no pain, no nothing. They just suddenly turn orange. The problem with pancreatic cancer is it extends very early to surrounding structures and it metastasizes to the liver and to regional lymph nodes. If the tumor happens to start in the body or in the tail of the pancreas, it's silent until it's very, very advanced. Most of the time, pancreatic cancer has metastasized at the time of diagnosis. That's what makes it such a devastating illness. In diagnosing, we don't usually detect cancer and the disease is advanced. An X-ray won't help. The CEA levels are elevated in 80 to 90% of patients. Amylase and lipase might be elevated. Now, for a patient who has an abrupt onset of diabetes, without any noted pre-diabetic state, that can be an early sign in 25% of patients. So anybody who has an abrupt onset of diabetes needs to be evaluated for pancreatic cancer. Alkaline phosphatase elevations can be due to either the common bile duct obstruction or a bilirubin elevation indicating liver metastasis. CAT scan provides a good overall assessment. The ERCP is the best diagnostic test. It will demonstrate obstruction or narrowing of the major ducts, and specimens can be obtained for cytology. The clinical manifestations are similar to those of chronic pancreatitis. They have a deep-seated abdominal pain. Recumbency increases the discomfort. Sitting upright with the spine flexed or the left thigh flexed may help. There's an unrelenting obstructive jaundice, and to go with that then, clay-colored stools because that bile is not being released into the intestines. They have a rapid and progressive weight loss. There's a palpable mass in 20% of the cases, and clearly if there's a palpable mass, it's almost always surgically incurable. If there's hepatomegaly, that indicates metastasis. And then migratory thrombophlebitis occurs in about 10% of the cases. Migratory, meaning, here and there and there and there, and thrombophlebitis, you know what that is. That by itself is not diagnostic because it also affects patients who have other types of malignancies. The most common symptoms of pancreatic cancer are jaundice, weight loss, and abdominal pain. What can be done? Well, a lot of times they may open the patient up, determine that indeed there is a pancreatic cancer with metastasis, and they close them up again, and they don't do anything. Now, the radical pancreatoduodenectomy, called the Whipple procedure for short, probably Dr. Whipple probably developed this. I really don't know the origin. This procedure is really only justified if all of the gross tumor can be removed and it's not involved adjacent lymph nodes, the liver, and areas near blood vessels. So about 15% of cancers of the head of the pancreas can be resected, but it is seldom possible for cancers involving the body of the pancreas or the tail of the pancreas because, again, those are very silent cancers and there's metastasis all over the place by the time that cancer is identified. So what they do is literally, here's the picture. All right, here's the pancreatic tumor. So what they will do is all this gray stuff gets cut out. So everything that was touching or anywhere close to that pancreas tumor gets cut out, including, while they're at it, might as well take the gallbladder out. So they take all this stuff out and then they put everything back together again. So if you look over here, what you have is the pancreas is attached to part of the intestine to reestablish pancreatic flow, pancreatic enzyme flow. The stomach is attached to a distal part of the intestine. That's the duodenojejunectomy. The duodenum of the stomach is attached to the jejunum of the intestine. The bile duct is attached to a portion of the jejunum. So basically what they've done is they've cut out everything that was close to the tumor and then they just kind of sew it all together again. Certainly, this patient's going to have a dumping syndrome problem. Again, it is not indicated unless they really think they can get it all because this is extensive surgery. Radiation is effective for pain relief, but it does not improve survival. Chemotherapy has got some limited success, but there's a lot of research going on in this area. Most patients are going to die within 5 months to a year of diagnosis. The overall 5-year survival rate is only 5 to 10%, and that's going to depend on the source that you happen to look up to find that information and the stage. I think I saw in one of the sources I was looking at, with the stage 4, it's less than 1% of patients are alive in 5 years. So this has a very, very dismal prognosis. And the goal of care really needs to be to provide as much quality of life as possible. Now, if the patient did have surgery, then of course there's post-op care, including care of drains, etc., that needs to be taken care of. And I do believe that that is the last slide and concludes this series of lectures on acute pancreatitis, chronic pancreatitis, and cancer of the pancreas. Have a good day.